Hi, my name is Katrina Jenner, and my poster is titled Crouching Tiger Hidden Infection Confronting the Unseen Challenge in Post-Transplant Care. Persistent leukocytosis without a clear cause can be seen commonly in inpatient settings. My case report emphasizes on a 75-year-old male with a history of immunocompromised state from his prior liver transplant and how he developed persistent leukocytosis and fevers with no clear cause. So we have a 75-year-old male who presented to the ER with a 2-day history of gross hematuria. Initially, on his first day, he noticed dark urine, which he thought was dehydration. He started passing clots the second day after developing some suprapubic pressure and believed that after noticing some frank blood in his urine, he decided to come to the emergency department, which led to him being admitted. He does have a history of hepatitis C virus infection, along with a history of liver transplant, benign prostatic hyperplasia, and bladder varices, which he had episodes of hematuria earlier on in his lifetime, and that was the cause, was the bladder varices. However, when he was admitted, urology was immediately consulted, and they observed numerous prostatic varices and clots within the bladder, which were fulgurated. The next day after admission, the patient developed a low-grade fever of 38.1 degrees Celsius. Infectious disease was consulted and recommended empiric cefepime with the hepatitis C virus RNA assessment, which ultimately returned negative. The prostate initially was suspected as the source of infection. However, a urine culture revealed gram-positive rods, which was consistent with skin flora. So the patient underwent a CT scan of the abdomen and pelvis, as seen in figures 1 and 2, which showed a lesion of the prostate, and radiology suggested that this could be a hematoma or an abscess. It also showed periportal edema as well. Urology stated that the mass was likely to be a hematoma, which would be consistent with where the operative site was. But given his worsening leukocytosis and fevers at the time, cefepime was discontinued and he was started on meropenem. His white blood cell count ranged from 15,000 at a minimum to 29,000 at a maximum. He then began developing recurrence of the symptoms with difficulty voiding once again and hematuria. So a nuclear medicine indium scan was ordered and showed no abnormal radiotracer uptake. So, given the persistent leukocytosis and fevers, the patient underwent an MRI of the abdomen and pelvis with contrast, which we can see in figures 3, 4, and 5. And this image showed findings consistent with a prostatic abscess. Additionally, there was an irregular appearing cystic lesion in the right hepatic lobe that was not present on the initial CT scans from earlier on in the admission, suggesting that this could be the site of infection. Liver function tests were immediately ordered given his history of transplant, and findings showed that he did have a transaminitis, and the patient was transferred immediately to a liver transplant care team at a tertiary care center for further management. So the importance of this case is to emphasize how carefully monitoring high-risk patients, particularly of those with organ transplant, even if they appear symptomatic but they have leukocytosis and fevers in mind, may be crucial in figuring out their ultimate diagnosis. So in immunocompromised patients, such as those on immunosuppressive therapy, such as this one, who was on CellCept and Prograft, it's very important to get a full picture and monitor the symptoms throughout the hospital course. The use of the indium-labeled white blood cell scans in this case was limited, as negative scan results were followed by further imaging, which revealed both a prostate abscess and a new hepatic lesion. However, in the conclusion, there's an article that we cited by Fisher that showed that white blood cell scans for fevers of unknown origin are not clinically useful and even suggested their complete avoidance. However, we did want to provide a full, thorough workup for this patient, and once this patient was transferred to a tertiary care center, findings from that center revealed a thrombosed hepatic vessel in addition to liver and prostatic abscess. So it's very important to use a proactive approach when helping these patients and make sure that you want to prevent potential complications and ensure that emergent issues are addressed promptly, ultimately improving their outcome.